Good morning, my name's Katie Ellis and I'm a nurse consultant at the Manchester Foundation Trust Wythenshawe Breast Clinic. I'm here today to talk to you about my experiences in implementing a new service and my internship over the last 12 months. Before September 2021, the idea of undertaking any research had never even entered my head. Having over 25 years experience as a qualified nurse, I had been involved in many areas of practice, but research had never been one of them. Give me a complex clinical scenario, give me an operational decision, give me service implementation and change management, and I'm fine. But as I was appointed a nurse consultant in 2021, overnight, research became a part of my professional life. But as you can see from the top of my poster, research to me was a foreign language. Back in 2010, the 2-week wait in all breast clinics became the standard for all breast patients. One-stop clinics became standard practice, involving same-day access to clinical, radiological and interventional procedures. However, the one-stop clinic has become a victim of its own success. Breast units nationally are overwhelmed with referrals, and many of those are for the worried well. Breast units nationally were struggling to cope with the increase in referrals, and this was all before COVID-19 struck, when the demands on services were compounded even further. COVID-19 caused staffing shortages due to sickness and redeployment, along with reduced footfall within units in order to comply with social distancing rules. This caused waiting times to increase, and more worryingly, patients with red flag symptoms had delays in accessing secondary breast services. With this in mind, implementing new ways of working for patients who did not require a one-stop service such as breast pain became a priority. So in 2020, shortly after the start of the COVID-19 pandemic, an AMP-led telephone clinic was identified as the most suitable way to manage patients with breast pain. A strict inclusion and exclusion criteria was created involving a full equality impact assessment. Patients were allocated a 20-minute telephone appointment and clinics ran twice weekly. Referrals were made by primary care directly into breast pain, but all referrals were triaged by the team to be sure they fitted the strict inclusion criteria. Those deemed unsuitable were referred back into a standard one-stop appointment. Patients were assessed with a solitary symptom of breast pain, and they were reassured and discharged. Patients over the age of 40 underwent mammography also at a deferred appointment. Anyone complaining of any further symptoms at the clinic were referred back into one-stop clinic for further assessment. It became evident early on in the implementation that an assessment tool will be helpful to assist with the diagnosis of the cause of the pain. It is widely believed within the field of breast care that a large proportion of breast pain does not originate from the breast but from the chest wall itself, and it is indeed a musculoskeletal problem. An assessment tool was not identified in the literature, and therefore as part of the protocol we created an assessment tool along with providing a package of care and treatment for each patient. The package of care included an individualised letter summarising the discussion, a bra fitting leaflet and leaflet reiterating the treatment for the pain. All patients were sent a patient survey questionnaire via text after the consultation. 1,238 patients were assessed in our clinic, with over 365 patients being reassured and discharged with no further intervention, and 609 having a mammogram as a deferred procedure, saving almost 1,000 one-stop clinic appointments. Of the 1,238 patients that we saw, 7 malignancies were identified, and these were identified on a mammogram after the event. This equates to a malignancy rate of 0.56%. And although we were not able to confirm that the under 40 population did not have a malignancy, we did look at the 12-month return rate data to see how many patients actually did return within the 12 months with the same problem or a different problem to see if we were missing anything. As you can see from the data, 2.6% of patients returned with the same symptom within 12 months, and an overall finding of 4% of patients returned with other symptoms. Only one patient returned within 12 months with a new malignancy, and this was in the contralateral breast to that she had breast pain. As you can see from the poster, patient satisfaction data was reassuring, with 97% of patients likely to recommend this service to family and friends. So here we had a great service. Capacity had been created for patients with worrying red flag symptoms. Patients with breast pain alone were receiving a better standard of care. Our data suggested it was safe, and patient satisfaction levels were high and return rates were low. But what do we do next? At this point, I felt that the ultimate goal would be to reduce the amount of referrals into secondary care and try and keep these patients in primary care. And with this in mind, I started my internship in October 2021. My initial thought was we could produce an app that created an assessment tool for patients that GPs could give to patients, that patients could use. We would reduce the amount of patients coming into secondary care. But what would the app involve? What assessment tool I would use? I had no idea. With the help of Sabine, firstly, we identified that the data needed to be published. I'd never published an article before. I had no idea what I was doing. And Katie Ellis from Wythenshawe Hospital, how could she possibly write an article about something and be taken seriously? But Sabine introduced me to the strobe guidance, and slowly but surely over the weeks and months we worked through this to try and create an article fit for publication. And I'm pleased to say that next month this hopefully will be published in a medical journal. My lack of knowledge in research also led to me undertaking a research module at Manchester University in quantitative design and analysis, which gave me a lot of underpinning knowledge which I hadn't previously gained. And with this knowledge, the gaps became obvious and the next steps became clear. Whilst an app sounded like a great idea, we were way off being able to implement something like this. Indeed, what we needed to do was create and validate an assessment tool for use in a non-patient facing environment. So where I am now, I'm considering doing another internship to gain even further experience and knowledge. I want to undertake a systematic review of the literature and identify any assessment tools that may exist out there. Then evaluate any tools and or create an appropriate tool for this assessment, ultimately validating an assessment tool for use in non-face-to-face clinics. And in conclusion, whilst many of the abbreviations in research still make no sense to me, I can honestly say that research isn't as much of a foreign language as it was when I started. Thank you.